Hello, I'm Chris Krueger, Senior Manager for Content at the Davis Phinney Foundation, and I'm here with Dr. Jonathan Isaacson to discuss a recent paper Dr. Isaacson published about the clinical utility of alpha-synuclein skin biopsies. Before we dive in, Dr. Isaacson, can you tell us a little bit about your background and your interest in Parkinson's and in the topic of alpha-synuclein?
Sure. So I'm a neurologist specializing in Parkinson's disease and related conditions and also autonomic disorders. And my focus is to improve how we diagnose and treat these conditions. So Parkinson's and other related disorders like Lewy body dementia and multiple systems atrophy and other Parkinsonism are notoriously difficult to diagnose early. And by the time we diagnose these conditions, many brain cells may already, have been lost. And using synuclein skin biopsies help us, make an earlier and more accurate diagnosis. So that kind of led to my interest. And our study was able to show that this test didn't just confirm suspected diagnoses, but it helped inform decision-making and treatment decisions as well.
Yeah, when I saw this article, I was really interested in it because I thought, well, this is exactly what we need to know. We exactly need to know what happens if we do this test? What changes might occur for us if we take these tests as people living with Parkinson's? And by the way, Dr. Isaacson, I know we spoke about this, but just for our audience, I'll say I happen to live with Parkinson's, so I bring that context to this conversation, of course. So to dive into this topic a little bit, can you just explain a little bit about what alpha-synuclein is and how it relates to Parkinson's?
Yeah, absolutely. So alpha-synuclein is a protein that can be naturally existing in nerve cells, but in Parkinson's disease and in some related conditions, it can phosphorylate and misfold and can start to form clumps, and it may contribute to neurodegeneration. And we know that it's present in other forms of synucleinopathies like multiple systems atrophy, like Parkinson's, and like Lewy body dementia. My dad tells this funny story, this interesting story actually, that when he was in residency, he saw a patient and they were coming to see him, but also Melvin Yar, who was a famous movement disorder specialist at Mount Sinai. And the patient saw, multiple different specialists in New York City, really well-known, famous neurologist, movement disorder specialist, and each of them told him he had Parkinson's. So Dr. Yar came in the room and said, well, you have, the typical resting tremor, you have, some rigidity, and it seems clear that you have Parkinson's disease. What makes this so hard for you to think that this is your correct diagnosis? And the patient said, well, 20 years ago, I was in the hospital and I was having a GI surgery, and they took a part of my gut and they looked at my gut to see if there was any malignancy or anything else going on. And one of the residents came in my room at 5 a.m., knocked on my door, woke me up in my room when I was trying to recover, and they said, "You may have Parkinson's." And it didn't make sense to me because I didn't have any motor features. I didn't have anything typical of Parkinson's disease. So I kind of passed it off. And then many years later, the patient says, it just doesn't make sense that 20 years later, I wound up having the same disorder that the resident from 20 years ago said I had. And what came to be known was that the pathology showed this abnormal protein, this alpha-synuclein, in his biopsy 20 years, 30 years before he even developed motor symptoms. And now we know that, Parkinson's and other related conditions can start in the body years and decades before diagnosis. So the skin biopsy is a way to measure synuclein in a very accessible way in the body.
And so the reason this is relevant, right, is that we know that many instances of Parkinson's and related conditions involve this protein sort of becoming out of its normal function or out of its normal shape, right? So that's why this is the neurologist in your story or the resident in your story was observing something that represented to them that there was a misfolding or somehow this alpha-synuclein was abnormal, and that's what drew their attention to it. And so I guess it's also worth saying that the alpha-synuclein is involved in what you would be looking for if you were to perform an autopsy. If I passed away and you were to do an autopsy on me, that would be a sign. If we looked at my brain, or well, I wouldn't look at my brain because I would be no longer able to look. But if one were to look at my brain and find alpha-synuclein, that would be corroborating evidence that in fact I had been living with Parkinson's. Is that right?
Exactly. And that was the typical way we would confirm diagnosis because it would be a clinical diagnosis and we would have, suspicion or high clinical suspicion that this was the correct diagnosis. But in order to clarify and confirm diagnosis, usually we'd have to wait for, autopsy to confirm the Lewy body and synuclein pathology in the brain. There's other ways of measuring synuclein in the heart, but it's a very rare test and not really offered in America. And then, like I said, sometimes it deposits in the gut, but most people don't want to go for, a gut procedure where they take a piece of your gut out to look for synuclein. So this would the synuclein skin biopsy is, one of the earliest, easiest ways to kind of identify synuclein in the skin in the autonomic fibers.
Yeah, so can you say a little bit more about what this skin biopsy test is? What does it involve? How does it work? If I were to have this biopsy test performed for me, what would happen? How would it work for me? What would I do?
Yeah, absolutely. So, what the test does is it takes three small skin biopsies. So it's not a major surgery. It's a kind of very small, minimally invasive, little, almost like nicking the skin a little bit with a little device we use, and it heals within a couple days. And we take three different biopsies, one in the shoulder area and then two in the legs, a very tiny clip of the skin. And then we remove that piece of skin and we stain it for phosphorylated synuclein, and we can actually get a great deal of information just from those three biopsies. The skin will heal within 2 or 3 days, and most people tolerate the procedure very well. The only painful part is when we inject a little bit of lidocaine, you may feel a little burn, but the rest of the procedure is painless, and then most patients don't feel any pain after the procedure. So pretty minimally invasive and very well tolerated and can give us a great deal of information.
Great. So it doesn't sound like it's too burdensome. I mean, we get shot with you get shots a lot for a lot of different procedures. So getting a little bit of a shot of lidocaine doesn't seem too bad to me. But so you perform this research study and investigating the clinical utility of this test, and what inspired that? Why did you choose? Why was that important to execute from your perspective?
Well, we know, in early diagnosis of Parkinson's and Parkinson's-like conditions, we're often either, wrong or we have to clarify diagnosis down the road. And then in atypical forms of Parkinsonism, have we can be wrong also in the early disease course. And then also really at autopsy, there's been a few studies that looked at, final diagnosis at autopsy, like we discussed, getting kind of confirmation with that with autopsy. And the disease can be incorrect in a great deal of patients, over 25% of patients. So that's just not good enough for our patients. So being able to diagnose these conditions more accurately, and having the right treatment options, a personalized care for our patients that's really tailored for each individual patient is very important to me. I just don't think it's good enough, even if we're, great movement disorder specialists and we can diagnose with high accuracy. 75% is just not good enough for our patients. They deserve to have the right diagnosis at the right time and be able to participate in the right clinical trials for the specific diagnosis, the right treatment options, the right life planning, and right rehab services, and really being tailored diagnosis for their disease course.
Yeah, thanks for clarifying that. I think it's maybe worth saying for a quick moment that we'll put some links in the description of this video to other information about the conditions that might be similar to Parkinson's and where there might be some discrepancy, so the audience here can find some more information on what these other conditions are. Um, so can you say a little bit about what you did to investigate the clinical utility of this test, and what did the study involve when you undertook it?
Yeah, absolutely. So we were looking for the clinical utility of this test. Dr. Gibbons and his team at Beth Israel was able to look at synuclein skin biopsies. And they were able to show that it has a very high diagnostic certainty in some of these disorders, over 90% for Parkinson's and related conditions in getting skin biopsy and confirming the diagnosis in these conditions. But no one really looked at the clinical utility. And what I mean by that is, how does it help the patient? Does it change the diagnosis? Does it change the treatment? Does it change how the patient is cared for? And that was the main thing we wanted to look for. So we looked at Parkinsonism and really indeterminate Parkinsonism. So we looked at different factors that can influence the diagnosis of Parkinson's and related conditions, such as tremor predominance, cognitive function, if they had low blood pressure when they stood up, if they had a lot of gait problems, if it was early in the disease course. and or if there was, a drug that was involved that can, cause some of the symptoms they were having. And then we looked at all those factors and we saw whether or not in about 100 patients, whether or not there was diagnostic changes and whether there was treatment changes in those subgroups.
And so what did you find? Were there changes? What are the findings that we can draw out of this paper that you produced?
So what we did, well, we noticed that these clinical features, particularly the low blood pressure, the tremor predominance, the cognitive symptoms, the gait problems, or the rate of progression, were often areas where clinicians found the biopsy most useful in these clinically indeterminate Parkinsonism. And if symptoms were atypical or overlapped with multiple conditions, the additional data from the biopsy seemed to provide a greater level of clarity, and it helped guide discussions on prognosis, management, counseling, and even sometimes referrals for clinical trials or further management of their specific disorder. Ultimately, the study underscored that diagnostic uncertainty remains a real challenge in these conditions, especially early in the disease course and in the atypical variants of the disease. And while a single test doesn't replace clinical judgment, it can serve a valuable piece of the puzzle in making more informed decisions.
Yeah, I'll say a little bit of my story or share a little bit of my story real quickly, just to say that when I was diagnosed with young onset Parkinson's, I was 37, and I thought, okay, this is really unusual. That's how it seemed to me. And
Yep.
I thought I went to the first person I saw for this, the first movement disorder specialist. I said, why are you sure this is Parkinson's and not something else? And I didn't get a very satisfactory answer, and it took a while to get one, and it was scary to me, frankly, to not have clarity about that. I thought this is rare already. Why not more rare? Why not less likely even? And so having this test at that point, I probably would have been interested in this if it was available at the time I was diagnosed. Um,
Exactly. And even and we don't think like this in other conditions. Like if you break your bone, orthopedists may say, I think you broke your femur, I think you broke your forearm, but we still get an x-ray to see, the severity and confirm diagnosis. If you have a stroke, we confirm it with MRI. So in these other conditions, we confirm with high clinical accuracy, combining both our clinical diagnosis and diagnostics to confirm diagnosis. And for some reason in Parkinson's and related conditions, there's some weariness to adding some of these diagnostics to help with clinical diagnostic decision making. But I think it's important, not just for confirming diagnosis, not just for having the accurate diagnosis and treatment for our patients, but also long term to know how these markers change with the disease course, how we can change it, how we can use, if we use different medications, is it playing a role in lowering the synuclein in the body? Is it something we can measure with clinical trials? There's many different indications for this test, and it's important to have kind of all our tools in the toolkit to better serve our patients and to treat Parkinson's and related conditions.
Yeah. So, what did you notice in this as you performed the study and looked at the documents you were examining in this study? Did you find any particular combinations of symptoms that were more likely to be correlated with a change in diagnosis after a skin biopsy test?
Yeah, so in our study, skin biopsies changed the diagnosis or management in these clinically indeterminate Parkinsonism in about 80% of cases, which was much higher than even what we anticipated. And this really highlights the potential clinical impact of having an objective biomarker in what has traditionally been a symptom-driven diagnostic process that can wax and wane, and we can, sometimes redefine or reclassify different diseases or different symptoms. And these changes involved adjustments in how clinicians approach symptom management, medication choices, or even long-term care planning. For some patients, a positive biopsy reinforced the need to optimize treatment strategies tailored to their specific neurodegenerative condition, while in other cases, a negative result led the clinicians to reconsider whether a different disease was playing a role in the process and helped avoid unnecessary medication or shifted focus toward alternate explanations. Beyond medication changes, which we saw quite a few of, we also saw that having this additional data sometimes influenced referrals, whether this was directed towards disease-specific clinical trials, engaging in earlier discussions about advanced care planning, or prompting more targeted rehab therapies. This underscores how objective testing isn't just about labeling a diagnosis or getting the right diagnosis. It's about shaping a more individualized precision approach to care.
Yeah, so it sounds like there's a lot of ways in which we're learning more all the time about how this test could be useful in informing various aspects of treatment. And I guess one question I wanted to ask you was, something I noticed when I read through the paper was that it really explored some of the biggest challenges that people face when they live with Parkinson's. From I'm thinking about things like postural instability and gait dysfunction. That's a really hard thing for people to manage. Freezing of gait in particular, for example, and autonomic problems, cognitive difficulties, tremor. I wonder if you can maybe go through those elements of those challenges that people might face and say, how is there something that your study sort of elucidated about these ways that the skin biopsy might affect the way I manage my gait dysfunction or my autonomic disruptions and cognition effects and tremor and things of that nature.
Yeah, absolutely. Going through each of those issues. So first, with the posture and the gait issues, some patients may not have the notable rest tremor that's typical in Parkinson's disease, and most of their symptoms may be in the lower extremity, and it may be gait predominant. But this can often overlap with other conditions that can mimic Parkinson's, like vascular Parkinson's, or like multiple systems atrophy, or like PSP, or like musculoskeletal conditions like arthritis. And having an accurate marker to clearly diagnose these conditions gives us greater influence in the treatment and affecting personal health of each patient individually. So for lower body and posture and gait symptoms, this test can help clarify which diagnosis they have and be able to treat it more precisely. In terms of autonomic dysfunction, like low blood pressure, like urinary symptoms, like constipation, we know this is present in all our patients with Parkinsonism, both Parkinson's disease, multiple systems atrophy, and other diseases like Parkinson's. Um, but this can lead to much overlap between the different conditions, especially if they have a lot of orthostasis, which is low blood pressure when they stand up. And it can overlap with conditions like multiple systems atrophy. So what we found in our study that the skin biopsy can help clearly diagnose Parkinson's versus MSA and point us more towards the right treatment options for these subset of patients. While they may get the same, medications for blood pressure, they may be a candidate for other trials or other targeted rehab services based on their condition. And that's what, the autonomic symptoms showed us that these overlap in diagnoses and we know in Parkinson's with the synuclein protein, autonomic is typically involved. But in other conditions like tauopathies, like Alzheimer's, like PSP, like cortical basal syndrome, we don't see as much autonomic disorders. And that was confirmed in our study that over 90% of our patients who had autonomic problems had this abnormal protein, synuclein. And it led to over 50% diagnosis and treatment changes in our population.
Can I jump in for one quick second? I think one thing that's interesting to me about this particular nuance is that, as I understand it, and tell me if I'm wrong, please, or I guess tell me if I'm right too. Um, I think that as I understand it, some other Parkinson's-like conditions or Parkinsonisms have less likely, there's less likelihood of response to levodopa and other medications that might treat well my Parkinson's symptoms, for example. Is that true?
Yeah, that's absolutely true. And that used to be one of the markers we would use to differentiate these conditions, but it's not so reliable. It's helpful that many conditions that are not Parkinson's disease may not respond as well to levodopa, but it doesn't, but it's just, one marker that can help us make the right diagnosis. It's not clear because some people with Parkinson's may need higher doses of levodopa or other medications that we have. We have so many new medications coming out and things evolving in the Parkinson's field, and they may need alterations to their medication. So just relying on levodopa responsiveness, which used to be one of the ways we differentiate these two conditions, is not what we found the best way to kind of differentiate these disorders. And also, but what it does help us is we can kind of clarify diagnoses, and if the levodopa they're not responsive to, and we confirm that they don't have a Parkinson's disease, but rather a related condition like multiple systems atrophy, it may not be the best decision to continue the levodopa if it's lowering their blood pressure and causing side effects.
So what about cognition and any other symptoms that you found a pattern in with regard to this study you performed?
Yeah, definitely. So, cognition in our study, cognitive issues led many patients to get skin biopsies, helping them better understand their condition. This is crucial because cognitive decline, which is continuing to increase in the general population, can overlap with many different conditions, including Alzheimer's, including Lewy body dementia, and including late phases of Parkinson sometimes. So, skin biopsy helped redefine the diagnoses with changes in treatment and diagnosis in over 60% of patients coming with cognitive changes. For some, patients were found to have Lewy body dementia instead of Parkinson's, which may have changed their medication plan. And in others, it clarified diagnoses and pointed away from a Parkinson's syndrome. Recognizing synucleinopathies like the protein depositions found in Parkinson's and Lewy body dementia can help us provide more accurate treatment and care for patients with cognitive impairment.
Is there any other symptom that sort of drew your attention when you looked at the results you were examining in your study?
Yeah, absolutely. Well, and tremor was one of the other, major symptoms we found that many patients were referred to a clinic for. And many patients, experience multiple different types of tremor, whether it's a rest tremor, whether it's a postural tremor, whether it's with action or holding different items, or it's more jerky and happens with certain maneuvers. Many patients have more than one tremor, and this can cause a diagnostic conundrum where we have to distinguish between Parkinson's and other related conditions that can have tremor. So in some cases, essential tremor can evolve into Parkinson's, making it even harder to diagnose. So the skin biopsies played a crucial role in our study, helping showing that accurate diagnosis of Parkinson's disease and essential tremor with diagnostic changes in over 93% of patients and treatment changes in 67% of patients coming to a clinic with tremor predominance. And this research shows that skin biopsy can help us identify the right condition and provide the effective treatment for patients coming in with tremor with unclear whether related to Parkinson's or other related conditions.
Yeah, so it sounds like there's just a lot of reason if there's any sort of just uncertainty that there may be a reason to think about this test for anyone experiencing that kind of uncertainty that often accompanies a Parkinson's diagnosis. It may be worth considering. And I guess, I'm in my experience early on, my first symptom I noticed, I would reach into the refrigerator, and as I withdrew my arm, I would have a tremor in my hand. And I thought, well, that's weird. And so I was expecting when I went to my doctor to go to the orthopedist. I was thinking they were going to give me a referral to work on my shoulder strength or something. And so I was very alarmed. And fortunately, I had a good team that I connected with, and so I had a fairly direct path to a diagnosis. But it was even in that context, it was really confusing to me. So I wish for myself personally, and this is just a personal thought for me, that this had been something I could have at least considered at the time I was diagnosed, because it would have probably helped me feel a little bit more comfortable with my diagnosis. And again, that's just my personal perspective. But I wonder, Dr. Isaacson, as we wrap up this conversation, if you have any other thoughts you'd like to share about, I don't know, maybe further improvements in understanding or advancements in um, that may be on the horizon because of the skin biopsy test and then the study you performed.
Yeah, absolutely. So right now, the test is mainly used for confirming synucleinopathies, but I see potential for it to become possibly a screening tool or used in the early prodromal phase of Parkinson's, especially in at-risk individuals before symptoms, even begin. We're also looking at quantitative measures, like how much alpha-synuclein is present and how much in each of those three sites I spoke about. And that can give clues to which synucleinopathy or which disorder they have, which could provide clues about maybe disease severity, progression patterns, how different diseases behave, and how synuclein deposition changes with time. Additionally, there's exciting work being done on combining this with other biomarkers like blood test or imaging to create a multi-layered, precision-based diagnostic approach. And the goal really is to catch these diseases earlier and with greater certainty, giving patients and doctors more time to act.
Yeah, I mean, all those things seem really important, especially if I think about the usefulness for clinical trial operations, for example, in terms of having clear vision into what the impacts of a treatment that's investigated in a clinical trial what those impacts that medication may be having. So that to me is another interesting layer to this that falls out of what you just said.
Yeah, absolutely. We've have made so much headway in the last 20, 30 years in new treatment options and all studies evaluating, changing the progression of these diseases. And in the years ahead, I believe we will have treatment options to slow and even stop these diseases, and better diagnostics, earlier and more accurate diagnosis of these conditions lay really the foundation for catching these diseases sooner and ultimately intervening before they take a hold.
Yeah, and all this is obviously to me, obviously anyway, very important. And so I'm grateful for your work in helping to elucidate some of these nuances of the way this test is useful, and in particular how it's useful to people today. Is one of our ambitions at the Davis Phinney Foundation is to help people live well today, and I think understanding what you're living with is a way to help you live well today. So, Dr. Isaacson, I want to thank you for your time and for sharing your insights into your study. And I want to just reiterate that we'll put some links in the description to this video that point to some of the more information about the topics we've discussed today. And yeah, I want to thank you for your time, and thank the audience for watching. And I look forward to connecting with you again in the future, Dr. Isaacson. Thanks again.
Of course, thanks, Chris. It was a pleasure.